Okay, welcome back. We're going to get going with the next presentation. So our next presenter is Dr. Walter Truong. Dr. Truong will be presenting what's new in spine and scoliosis. Dr. Truong is a pediatric orthopedic and spine surgeon at Gillette's Medical and the medical director for orthopedics. He earned his medical degree from Ohio State University and completed his residency at the University of Minnesota. So Dr. Truong, all you.
Well, while that's loading, yeah, I'm Walter Truong, one of the pediatric orthopedic surgeons here and spine surgeons. Most of my elective practice is spine, but I do some trauma as well a day a week over at Minneapolis Children's, and our group actually covers that. And this talk is mostly focused on scoliosis due to the time limitations. And it's the most common thing that we see here. But I'll also talk about some of the more rare presentations of scoliosis, including early onsets and infantile scoliosis. So I also do research through the University of Minnesota Department of Ortho, and that's around trauma and spine deformity as well. So here's our outline. We'll kind of talk about scoliosis and a systematic approach to it. They'll kind of talk about what's new, and most of the newer developments within the last decade are around scoliosis in terms of pediatric spine. So I'll talk about what's a little different than maybe what you trained on or what you heard about, and certainly what's different from what your parents may have experienced. So scoliosis dates back a very long time. It actually just means a curve of the spine to the side, and we define that as 10 degrees. So anything less than 10 degrees actually is not truly scoliosis. It actually takes more than 10 degrees to fit the diagnostic criteria. And it is a curve to the side, but it really is a three-dimensional problem. And it has many causes. We really don't know what the real cause is, right? You've heard this multiple times before. I tell families it's partly genetic, partly environment, but the true cause we don't know, because twins don't always get it. So identical twins may not get it. So there's something in the environment that's causing it. And there's also not one single gene that causes it. So we haven't been able to identify one gene that is passed on in all families that tend to get this. So it's still an unknown, and you can win a Nobel Prize certainly for figuring this out. It is a three-dimensional thing. So whatever the cause is, what we believe happens is the end point is that there's a growth of the spine in the front that happens faster than the back. So during that rapid growth spurt, the front of the spine grows faster than the back and spins out to the side. And that's what causes then the spine to look like it's curved to the side, but is actually rotated. And this rib hump that we describe is actually the ribs and the muscles that are attached or next to the spine as it rotates out to the side. So that's why it always flattens in and then rotates up and out. And we use that actually as a screening tool. And this is the screening tool we talk about. It's a Adams forward bend test. And we have them, I always tell them, feet together, keep your knees straight, lean forward, and try to touch your shins or your knees. You tell them to try to touch their toes, they always try to bend their knees, and it ruins the test. So this is a scoliometer, which is a fancy level, essentially, that has a cutout in the middle for the spinous process to sink into. You could use your iPhone, and on my virtual visits, I have families just bring out the level tool on their phone and do it like this, where they just stick their thumbs underneath to keep it above the spinous processes. And we use actually 5 degrees, you will catch all of them, but then it's too sensitive. You want to catch it at the right time when you have a curve that you would likely intervene on. So 7 degrees is our threshold. So in the primary care offices, we recommend you do the forward bend test and have a level if you have that available. You can use the phone or any sort of level that you have, and 7 degrees is a threshold for an X-ray. So outside of that 7-degree range and screening with an X-ray, you also want to rule out other things. So sometimes it's idiopathic scoliosis, and sometimes it's not. So scoliosis is associated with a lot of other conditions, and a lot of them are genetic, and some are neuromuscular, but you want to make sure you don't miss those. So these things are like checking the skin, making sure the reflexes, the abdominal reflexes are normal, check the feet to make sure you don't have this cavus deformity, make sure there's no hairy patches or things in the back that could denote some other issues neurologically. So we're talking about cafe au lait spots here and hairy patches, sacral dimples, things that would say maybe there's something else going on that's causing the scoliosis and not just this partly genetic, partly environment issue. So this is one of my partner's fun sayings that he likes to use is no spine exam is complete until you look at the skin, belly, and feet. He likes rhymes. So you can also look at leg length difference, and there's multiple ways of doing that. So sometimes you'll have a postural scoliosis where because one leg is higher than the other, is that you'll have this lumbar curve because the pelvis is then tilted. There's different ways to check for leg length difference, like rulers and all that laying down. I find that the most accurate is have them put their feet together, keep their knees straight. You can check at the iliac crest, but I find that that's far apart on each side. If you can find the PSIS, which on most people you can find a small dimple in the back there, the PSIS, you could see if there's a leg length difference pretty easily. That's the most consistent way that I found, short of the x-rays, of course. All right, so how do we talk about scoliosis? We talk about it as based on age, actually. So the age of presentation is very important in terms of prognosis and also our treatment recommendations. So the most common is adolescent idiopathic scoliosis. That's from age 10 until skeletal maturity, and that is about 3% of the population, so 2 to 3, more common than redheads. And it's often a right-sided curve in the thoracic spine. That's the most common. Sometimes you'll have a lower curve in the thoracolumbar, but also left-sided lumbar curves are very common. So this is the typical presentation that you see on this x-ray here. And we have some rotational changes. That's what makes it structural. So that forward bend test has to have some rotation. If it doesn't, then that's unusual. But they should be actually fairly balanced. Their trunk might be shifted to one side, but often because they're neurologically normal, they keep their head on their pelvis nicely. There are atypical curves. So these are curves that are to the left side, and they can be shorter. They have other issues like no rotation, some balance issues, rapid progression more than you would expect, pain. So scoliosis is generally not associated with pain, especially in the more mild to moderate range of curve sizes. And it should not be severe or activity limiting pain. So if there's pain related to this, then it's generally not idiopathic scoliosis. You want to look for other issues. This is a child with a curve to the left side without very much rotation, and it seems fairly fixed. And we went and looked with an MRI, and there's a large syrinx in the spinal cord there. So when we see a curve, when and why do we recommend treatment? And what do we tell the parents in terms of prognosis? The two big takeaways here are the younger the child and the larger the curve, the worse prognosis in terms of progression. This is a landmark study by Dr. John Lonstein from here at Gillette. This is one of the most cited papers in all of spine. And it talks about the more immature here. I talk to patients about once the curve gets over about 20 to 25 degrees, there's about a 2/3 chance that that's going to progress to the point where we may be talking about surgery. And as we talk about long term, so why does it matter if it progresses or not? So if you have a little progression and it's not painful, why do we worry about it? If they're not symptomatic, why does it matter? Well, if it gets big enough, there's a tipping point where even after you're done growing, it won't stop. And that's why we care about it. And if it keeps going and gets to a certain point, there are symptoms that are related to it. So there's a paper out of Iowa that looked at this in terms of mean follow-up of 40 years, which is really hard to do, except for if you live in Iowa for some reason. But thoracic curves less than 30 did not progress generally, but those over about 50 degrees did progress about 1 or 2 degrees a year. So even if you think about half a degree a year, 10 years, as a 5-degree increase, which is not a big deal. But if you talk about 2 degrees and you're at 50 degrees at 20 years of age, in 10 years, it increased 20 degrees, then you're already at 70 degrees. And we'll talk about why that matters. So when it gets to a certain size, so you can see this curve here in terms of your lung function here, FVC and FEV, is that it declines as the curve gets larger. And where that becomes, less than 80% of predicted, once the curves get about 80%, 80 degrees or so, I talk to families about 75 or 80 degrees, it does become symptomatic. And that includes like almost twice as much in terms of back pain, the adverse cosmesis, certainly the patients do not like the way it looks, and then the decrease in pulmonary function like we talked about. Now for idiopathic scoliosis, meaning scoliosis that started after age 10, it doesn't decrease your lifespan though. It doesn't interfere with childbirth, it doesn't decrease your life expectancy, it doesn't change marital status. So these are things that you do have to put in context. So it's for back pain, the way it looks, and some restrictive lung disease. It's not for shortening your life or causing, limiting your activities in terms of jobs you want to do. That's what I tell families. So in terms of managing idiopathic scoliosis in teenagers, just remember these things. This is a little summary as we go. 7 degrees or more, you should get an x-ray. It can be at the primary office or send it to the specialist. You can get, if it's less than 10 degrees, you can actually follow with a forward bend test and make sure if that changes, then get another x-ray, or you can repeat every year or so. If it's between 10 and 15 degrees, though, you do want to repeat that every 6 months, especially while they're growing, and especially if they're growing quickly. You can refer at any point, but certainly if it's over 15 degrees, so that we can consider bracing and other options. And certainly if there's any change in the curve and progression, we want to see them. Now, we talked about just idiopathic scoliosis, so none with congenital anomalies where there's fused bones together or extra pieces of bone or missing pieces of bone. We should see those at any age to make sure that we follow those closely. So now we have this curve that is, let's say, over 20 degrees, and we're considering treatment. So what are the treatment options? So everyone's heard about bracing for the spine, and we'll talk about that certainly, but we'll talk about a few other things that we've learned over the years recently that we've added to the regimen. So in terms of non-surgical, we're talking about vitamin D, bracing, therapy, and casting, and then we'll talk about surgery after that. So factors that influence treatment, we just got to make sure it makes a difference and it's tolerated. And we're talking about kids that actually need treatment. So we want to make sure that they're still growing. So if they're actually done growing, like I said, bracing and most of the non-operative treatments have no effect. And we assess maturity by various means, and that includes the Risser sign, which people may know about, which is this cartilage cap that goes on top of the bone here, and we divide it into 4 quartiles, and 5 is when it's fused completely into the bone there. Now 5 looks exactly like 0, except that you will know the patient's age and whether the triradiate cartilage is open. The one that is most reliable right now for us, and the one we use most often, is actually a bone age. So it's a left-hand x-ray that we use, and we use a little different from the classic bone age. We actually use a Sanders classification, which is a 1 to 8 scale that was developed more recently. And it's looking at the different growth plates closing from distal to proximal, essentially from the distal phalanx, then the intermediate, then proximal, and then the wrist is actually the last one to close. This has been looked at and validated very well in terms of risk of progression based on curve size, more accurate than chronologic age and more accurate than Risser. So another change is vitamin D. We have recommendations here, or 600 milligrams of calcium, 800 IUs of vitamin D3. that we recommend in all patients at the diagnosis of scoliosis. There are some studies that are a little bit weaker in terms of level of evidence, but strong enough that the treatment has such low risk that we recommend it for almost all of our patients. Since we live in Minnesota, it's easy to be a little bit low in your vitamin D. The other thing that's a little bit newer is spine-specific exercises. So there are different schools on this. The most common is the Schroth school or the Barcelona school. And we have therapists that are specifically trained in this. You have to do special certification for it. The therapy is fairly intensive. But the goal is actually to augment bracing. It's not to replace bracing, which has very good level 1 evidence, but it's to augment it. It actually is very clear based on the evidence that the therapy is very good for self-image as well as for pain. In terms of changing the natural history of the spine curve and whether it's better than bracing alone is still unclear. So we are following our patients in a registry and seeing if there is a difference, and there are multiple studies around the world that is looking at this, but that answer is not clear yet. For me, I tell the patients that it is an augment, meaning you learn how to hold your spine in a straighter position like a brace would do, but without a brace on. So it allows you more hours out of the brace, and those hours out of the brace still being able to control your spine and get stronger in terms of the biofeedback. But in terms of whether that truly is better than bracing alone, again, is not clear. Now, in terms of bracing, you've heard of bracing, up to the neck in the old days. You heard about 23 or 24 hours a day. That does not happen ever now. So we almost never say never, but almost never prescribe a brace that goes up under the chin, up in the neck. And you may have heard of people that have had that in the past. And we also have different brace options that we didn't have in the past. So we have a full-time brace, and full-time for us is not 23 or 24 hours. It actually is 16 to 18 hours. Now, we prescribe it generally 18 to 20 based on the research, but knowing that probably 16 or more is adequate. And then there's a nighttime hypercorrective brace that's worn only when you're sleeping, and this is really more newer in terms of prescription. And we're still trying to figure out what is the best patient for the nighttime brace, and does it work as well as a full-time brace. So we'll talk more about that. So for a brace to work, it's got to be worn and it's got to be tolerated, and it can't interfere with the patient's life to the point where it's affecting their mental health. And that is actually a problem. The more we study it, the more we look at it, it's very clear that that's a problem. And I started doing nighttime braces probably about 10 years ago because of a patient that was struggling so much with the full-time brace. And that they were just fighting between mom and daughter to the point where it was affecting their relationship in a very, very detrimental way. But in general, the bracing recommendations based from the Scoliosis Research Society and our national societies is to brace anything that's around 20 to 45 degrees, wrists are 0 to 2, meaning you still have significant growth, and Sanders less than 7. That was based on that hand x-ray we talked about. This is the study that tells us that braces actually work. This is a landmark study, again, led by the team in Iowa, but multi-center. And their primary outcome was curves over 50 degrees, meaning recommending surgery. Again, curves 20 to 40 degrees with a brace that's prescribed 18 hours a day. They had temperature sensors in it, and that was able to track to see if they actually worked those number of times, and we'll talk about that data too. But their primary analysis, again, was to surgery or 50 degrees where surgery is recommended. And you can see that the brace was much more effective than no brace. And a lot of centers actually entered this thinking that it was not effective. They were not believers in brace at all, and this really helped prove that the brace is helpful. The study was actually stopped early because it was becoming unethical to randomize to observation. So there is a dose effect, and this also proves that there is a treatment effect of the brace itself. So the more hours that the kids wore the brace, the less chance that they would progress to 50 degrees. And you can see that actually over 13 hours a day, you see a significant effect already. And you max out around 18 hours. So somewhere around between 13 and 18 hours, there is leveling off. And certainly over 18 hours versus that 16 to 18 hours doesn't seem to be much of a difference in terms of success. Less than 6 hours, you're essentially the same as no brace at all. So you certainly want to wear it at least that amount of time. Now, so even if you're doing 16 hours a day, that does mean that you're wearing it during the day at school a lot of times. So that's where some patients just can't tolerate it there for lots of different reasons. And this is where the nighttime brace, it's a little lower profile, it's hypercorrective, it can push a little bit harder and correct a little bit more because you're laying down in the brace. So that's where the design is significantly different. And this is only worn during sleep hours. So really the 8 hours a day, a lot of kids sleep up to 10 hours, but it's essentially 8 to 10 hours, less than that 13-hour threshold that we're talking about with the full-time brace. Now at our center here, we actually did a meta-analysis where, we looked at all of the research currently available on it. And it did show that the more mature kids and the kids with lumbar curves did actually very well with the nighttime braces. And this is where we've kind of incorporated those patients into our practice, getting the nighttime brace without worrying too much. It's the other ones that are sort of in between, where there's still a lot of growth and it's a thoracic curve. We still don't know what the right answer is there. Also, those papers were all retrospective and not high quality, and so we do need better evidence for this. So I'll go through some of this literature quickly, but you can see these are plots where the confidence interval is this broad band here. So the wider the diamond, the less you can actually comment on it in terms of the grouping of the studies. The tighter that diamond, then you can make a comment where more likely that that's a true finding versus a finding that is spread out and not sure if the evidence is conflicting or not. So what we do know, like I said, is that thoracolumbar curves are lower curves, and those kids that are a little bit older are going to do okay with a nighttime brace, we believe. But the ones that are younger and with curves in the thoracic spine, we're not sure. And we actually did a survey of surgeons out there, and actually up to about half of the surgeons in North America are using nighttime braces, despite the evidence being, pretty questionable at this point. And with 50% using braces of the nighttime braces, we gave them a bunch of case scenarios and asked them, would you be willing to randomize or not? And a lot of them wouldn't prescribe a brace in those situations, but a lot of them would be willing to randomize to figure out if they knew the answer, if the answer is correct or not in terms of the way they're prescribing. So there's a lot of question marks out there, and I think there's a lot of hope for the future that we'll know more soon. All right, I've been talking a lot here. I need to take a break. So severe scoliosis. So that's a thing between bracing and non-operative treatment versus the severe curve. So we talked about bracing 20 to about 40 degrees, because actually over about 40 or 45 degrees, there's a threshold there where bracing no longer is effective. And also somewhere around 45 or 50 degrees, those curves, like I said, from the Iowa study, will continue to progress even into adulthood. So this is now where we're talking about the severe curves that may end up with more back pain, more image problems, more restrictive lung disease. So what options do we have for those patients where bracing is no longer an option and non-operative treatment is no longer recommended? Well, we have spinal fusion. Now, everyone's heard about spinal fusions. They also have lots of horror stories from grandparents or aunts and uncles that have had this, where they were in casts or they had severe pain for a long time or in the hospital for, weeks at a time. That's no longer the case. For a spine fusion, for us, you're usually in the hospital about 3 days total, including the day of surgery. You have no brace afterwards. You're up and walking right away. You shower in 2 days. You're back to school usually around 3 weeks or so. I usually let my patients start running at 3 months and back to full sports at 4 months. So that's, and we can get this nice correction where, again, we're opening the lungs up nicely, getting the balance back, and then locking this in for life. Generally done with majority screws now instead of hooks. And because we're using the screws and larger rod diameters, they're much more rigid fixation, and that's why we don't have to use the braces. That's why we can mobilize so quickly. And so that's changed a lot. We've also focused more on the sagittal plane and sagittal balance, meaning from the side, which seems to affect long-term outcomes more so than even fixing the curve sideways. So there's lots of different things that we approach now that's different from before. So this is a newer technology here called vertebral body tethering. Now, this has only been FDA approved, I think, less than 5 years now. And we do it here as well. And I think there's a select group that this is really designed for. This is a growth modulation of the spine. You may have heard growth modulation in the legs. And this is of the spine, where we put a flexible tether, which looks like a shoelace, essentially. We use a scope to go into the chest area, and we do a mini open for the lumbar aspect of the spine. And we place screws in the front of the spine and then connect them together with the shoelace I talked about. That initially gets them nice and straight. And in about half of the cases, or slightly less than that, they actually can even straighten a little bit more as they grow. The idea is to remodel the bone and also even allow it to grow straighter as they finish off their growth. So they have to be young enough for this, meaning Sanders 3 or 4, and certainly Risser less than 2. And that's very important. There are centers around the world that are trying this in more mature people and adults, but we know that these tethers break at about 2 to 3 years. The majority, over half of them, are broken by 2 years. So if you don't have growth to modulate it and you don't remodel that bone, it's likely going to fail and go back to where it was. So this sounds like a home run. This sounds like you maintain your motion, it's less bleeding, but there's actually a higher complication rate in terms of overcorrecting, undercorrecting, having blood around the lung because you have a little scarring and tear from around the heads of the screws. So, nothing's for free. And this, if this goes well and is great, it's a great, great surgery. If it doesn't, there's still about 18 to 20% that need a fusion anyway. So you're talking about somewhere between 1 in 6 that need that have to go back and get a fusion even after this surgery. And then there's another group that overcorrects or undercorrects. And you also can't correct the rotation. So that rib bump that you have, most of the patients that get the tether don't correct that. So not everyone loves that. But for the right patient, this is actually a fantastic surgery. I have them return to sport by 6 weeks, and it's a really nice surgery. So who's eligible? Again, you got to be over 9 years of age to not overcorrect. You have to at least 2 years of growth remaining, so not to undercorrect or not be flexible enough. The curve has to be flexible and more mild. So if you're over 65 degrees, I think that often is too stiff. And we've learned that over the years from other centers as well as our own. It has to be idiopathic, so kids with other syndromes or neuromuscular problems, it's just too unpredictable. There's already a high revision rate, and that would just skyrocket it too. So the FDA approval is for idiopathic scoliosis with a very tight indication window. This is the look inside of the lung itself. So that's the thoracoscopic view. as we actually do single lung ventilation and deflate one lung, and we kind of work on the side of the spine right next to the ribs there, put the rods in. And you can see that this patient of mine actually did modulate, meaning as she grew, it did correct more, but that doesn't happen in all patients. All right, so this is a little guide for idiopathic scoliosis in adolescents, so 10 to 18 years of age. Less than 10 degrees, you can just watch. 10 to 20, you definitely want to follow with serial radiographs. We'll brace between 20 and 45 degrees, and then over 45 or 50 degrees, really in our hands, it's 50 degrees. We talk about surgery. In some cases where they're very immature, we will offer the tether for over 40 degrees. All right, so I'll kind of blast through. We're getting close to the end, so we have some time for questions. But some early onset scoliosis is those kids less than 10. And then again, this is a different animal. So if I said no increased mortality in severe curves in adolescents, but severe curves in early onset, less than 10, actually does decrease their life expectancy because their lungs are still developing. If it gets very severe, it can affect that. And our surgery sometimes stopping the lungs from developing and growing appropriately can be a problem. So we have these magnetically controlled rods. So if the kids are certainly less than about 8 or 9, we don't want to fuse the spine and just stop it where it is. So we have these rods where we can lengthen in clinic. The old days, we used to open the spine up every 6 months and manually distract it and then lock it back in. Now we use the magnetic rods, and every 3 months in clinic, just do this with large magnets that spin, and they lengthen the rods, and the rods lock in at the new length. And you can see it starts together and then it gaps apart like this, and you're able to then correct the spine as they grow over the years. These rods need to be swapped out as they run out of length every about 2 to 3 years. So if you start at 4, you probably need to replace it at least once. But if you start at about 7 or 8, then we can transition to a fusion by age 10 or 11, and they do great. All right. There's also an infantile type of scoliosis that starts before age 4. And this is about CP. You know, unfortunately, we're not talking about CP today. I think that would be a nice topic on its own in terms of a topic for discussion. And I'm happy to answer questions about CP. Unfortunately, CP has a lot less options in general. Bracing in neuromuscular populations has not been shown to be very effective in terms of stopping that. We are in the middle of a systematic review of the current literature, and it's not very good. We are actually planning on doing more prospective research on non-operative management of neuromuscular curves as well. But it's because the neuromuscular diagnosis is so broad, it's actually a very hard topic to study. Now, fusion is very effective and actually very safe in most neuromuscular populations. We generally do fuse from most of the spine, from the top of the spine down to the lumbar area for most ambulatory kids, and then into the pelvis for most kids that are not ambulatory. So we can talk about that in a few minutes here. I'll just finish off casting for infantile scoliosis, which is a much more rare issue. We have most of the infantile scoliosis actually resolves on its own, but there are certain small population that fails. And this is the only time where we really cast the spine, and we have special. We actually have special tables for this and special techniques to make that happen. But this is actually where non-operative treatment can cure the spine, where casting, if we get them early enough, less than age 3, we can actually take a curve that's fairly significant with rotation and actually make it straight and maintain that for the rest of their life. So again, this is a different diagnosis and a different treatment algorithm. All right, so again, AIS is what we focused on mainly here, and this is focusing on nighttime and vertebral body tethering. Again, we have low dose radiation machine called the EOS, and it's important that I mention this because a lot of times kids with neuromuscular scoliosis or idiopathic scoliosis will have a lot of x-rays, and decreasing that radiation as much as possible is an important thing. And this is a newer technology in the last few years that we have at our Maple Grove and St. Paul sites. This is our spine team and multidisciplinary, and don't hesitate to reach out to me at any point with any further questions about this and about neuromuscular scoliosis, which is about half of my practice is actually neuromuscular in nature, and that's a big part of what we could talk about in another talk, unfortunately. Yeah, I actually do recommend the vitamin D within the neuromuscular population as well. I also will have a shorter leash for asking for vitamin D levels in the neuromuscular population to make sure that we're on top of that. Bone health is already an issue in most of our non-ambulatory patients with neuromuscular conditions. So having a vitamin D that's at a normal level is very important for them in general. Yeah, that's a good question. I would say that anyone under 40 degrees, I certainly would brace. So it's the ones between 40 and 50 degrees that's a little bit of a question mark. If they are 40 to 50 degrees and Sanders 5 or more, then they're probably lower risk, and we would want to probably brace those. They're also probably too mature for a tether anyway. So it's really the ones that we think that a brace is going to fail most likely. So that's Sanders 2 or 3 or even up to 4 for the lumbar curves. And most of the time we're tethering lumbar curves much more than thoracic curves because they are more flexible, they respond better, and seem to modulate better. So we do have a few more minutes if anybody has questions about even neuromuscular scoliosis or anything that we talked about in terms of the newer treatments that we've had. I would say that neuromuscular scoliosis also has a fair proportion of early onset scoliosis, meaning that they start before age 10. So, a lot of our patients do have the magnetic rods and other things that we do to delay the fusion as long as possible. Unfortunately, fusion is still our number one treatment across diagnoses. And the good news, though, is that fusions are very predictable, fairly low complication rate, and they're durable. They last their whole life. And we've done studies in terms of patient-reported outcomes that do show they make a difference in terms of improving quality of life. So in terms of the metal rods, it's very rare to have breakage of those rods. Oh, in terms of the magnetic rods, yes, you do get that sometimes. So the magnetic rods have a higher complication rate than the solid rods because you're only fusing the top and bottom, and then in between you are maintaining motion, right? So that's what allows growth. So in terms of I'm going to stop presenting so I can talk. But so in terms of the magnetic rods breaking, we see that the low tone is less likely because there's more stress on it. But even with high tone, we have larger rod diameters now, and we also have dual rods. We almost always put in 2 and almost never put in 1 alone. And we put more anchors at the top, especially 6 anchors. These things have really decreased the complication rate with the magnetic rods compared to what's published in the literature and what's been historic, longer than say about 5 to 10 years from now. So the way we did it, even 10 years ago as a group is very different from the way we do it now based on research that's come out and research that we're part of. Yeah. No, I think actually the magnetic rods have a pretty good profile now. Like the next generation rods that have come out now and the diameters that we have available, it's actually a very very good option. Is there discomfort when lengthening? No. So actually the lengthenings are, the kids that can tell me whether it's uncomfortable or not say that they just feel a stretch of the muscle. So they feel really tight for about 30 seconds to a minute right after the lengthening. I usually do about 1 millimeter at a time to let it rest. And then we usually end up doing about 3 to 5 millimeters most of the time, every 3 months. So it's not a lot. It's enough for them to feel a little bit tight, but they don't need any pain medications. They don't need any sedation. It's done just right in clinic.
All right, thank you very much, Dr. Truong. We appreciate it. I think at this point we should take another 4-minute break. Reminder, we can continue to put questions in the chat. We'll come back and do those as a group at 11:15. So we'll see everybody back in about 4 minutes.